welcome to session number 3. And we've got more in store that we'll talk about at the end, so you'll have to wait to hear about that. However, as we've had covered, we touched on neuropathy approaches, and hopefully some of you have pulled out that reflex hammer, maybe shined it up, or at least put it within a visible range. I hope some encouragement that way. And certainly, as we learned maybe different ways of thinking about where pain may come from, how we quantify it. And then we had some excellent discussion with Dr. Dex Arnold on our second session, where we've got an approach of looking at dizziness through the vantage point of a time stamp and in terms of provocative maneuvers. And then we had the benefit of also having a vestibular therapist, audiologist, Erica Zia, joining us up on stage and making me make vertiginous sounds as well. So it's been a pleasure to have more interactions. And as such, I would encourage people to have their videos on at least for a period of time, because this is the way that I can actually look at your names a little bit more sneakily and connect a face to a name, because I couldn't see you guys all across the way, and especially not while having a talk. But this is certainly a means to connect. So speaking of which, just briefly to talk about what this, where this manifested as part of a shared care project, where we're trying to bridge a link between family physicians and neurologists to the next level, where we can both elevate our practice and the patients that we see. And so this has kind of been a project now moving on towards 2 years. So it feels like a partnership, some might say a marriage. And like all marriages, you start getting into some understanding that some conflicts can't be won, but we can understand our limitations and we can grow all together and beyond our own given limitations. And this is one of these ways of doing that, to talk about what we can do for one another, for our patients. And another aspect that has grown from this is to encourage that the family physicians out there reach out to neurologists through RACE app or other means of communication, so that we can, whether it's better triaging, or whether it's to be able to answer the patient's question in front of you in a more timely manner. And so I think that can drop our wait times and improve the quality of care. So I'm really pleased to introduce our next speaker, which is Dr. Danah Abo AlSamh. We've got her practicing in, well, not we, but she's got herself practicing at Royal Columbian, Surrey Memorial Hospital, Peace Arch Hospital. Both her and Dr. Arnold have really set up a wonderful position at Peace Arch Hospital that seems to have grown under their care and keen intentions. She's a keen neurologist that also works at coastal clinics. She's looking at acute and chronic conditions with attention particularly to stroke, migraine, and dementia, as we will find out. And I do appreciate her deeply in neurology rounds to see her wonderful, keen mind give input and teaching me throughout these sessions. And I'm about to have that same experience once again here. So I'm pleased to have Danah share the stage and bring us past our limitations.
Thank you so much, Elliot. That was an incredibly kind introduction. I'm glad that you're not deeply annoyed by me, as I am sometimes by myself. I hope everybody can see my slides. And it's a great honor to be invited back to the division. Surrey, White Rock, and North Delta is my home, essentially, and I really enjoy practicing here. So I've been asked to present on this topic, which I think is a little bit of a heavier topic, but I think is so important as we look after older patients. I'm trying to hopefully break it up into two components. I've got my clock timer here, my kids timer here that tells me when I should be giving people a break. But this is a topic that I can talk about for many, many months, many, many hours. Maybe not months. I sleep, but I wouldn't. I would probably cannot shut up about this. So hopefully today you'll learn something new and it'll hopefully help you with managing our shared patients. Because some of these patients I will, I'm sure I'll see for you. So I don't have any relevant disclosures whatsoever with regards to the topic of cognitive impairment or dementia. I thought today that we would sort of talk about what normal aging is because there is a lot of worried well out there. I thought we would also talk about an approach to the cognitively impaired patient. And then, sort of halfway through that topic, I thought we would take a bit of a break, stretch our legs, and get something to drink, and then kind of delve a bit into Alzheimer's disease, some management strategy, and then at the very end, just touch on safety. Um, so I'll get started. As you all probably know or have heard of the uh, so-called silver or gray tsunami that we may be facing with an aging population. I wanted to show you that in Canada, the population is actually mostly in the older ranges at this point in time, and over the next several years, we'll see a growing number of patients who exceed even 85 and older, and that will bring these disorders all to the forefront and mandate that we all are aware of what's going on and what's available. So that is where this also comes from. I wanted to ask about normal aging and if anybody has gone through their 40s, 50s, or 60s, as anybody may know, that there is actually a change that we all go through from a cognitive perspective as we age, and it's important to identify what is that normal aging and what is not normal aging. And the question begs itself is, are we all in decline? And I kind of like to start um, from that perspective because it is a little bit reassuring to know that past the age of 25, our brains are going to start to atrophy. We mature at that point, but also immediately start to decline thereafter. So there's lots of studies about normal aging and what is considered normal and not. This is a challenging population to actually study because we know that it also has patients in it that are like just the older population, patients in it that may evolve at some point into experiencing neurocognitive disorders with some latency. So this is a tough population to study, but we know that there is changes that occur with regards to the different types of intelligence and capacities that we have. So we're all born with a type of fluid intelligence. It's almost like your native mental ability. And this seems to decline with age. However, there is an alternate form of intelligence called your crystallized intelligence, which basically is your sort of self-directed learning and self-improvement type of activities and knowledge base that continues to grow as long as you are alive. And the decline in fluid intelligence with the increased in crystallized intelligence tend to offset each other. Um, we're all shrinking, as I mentioned. So there is an annual rate of decrease of about 0.4% in our whole brain volume. And this has been observed across a totally normal population of people. It ranges between 0.3 in our 40s and up to 0.5 for people who are in their 80s. And by virtue of that, our ventricles are going to dilate a little bit. And you often will hear that on reports, for example. So you can see here on these sort of plots of normal aging people. that the blue is actually men and the red is women. And you can see that over time, there is a bit of a peak with regards to the volume of the white matter, the gray matter, the subcortical gray matter, and that tends to decline over time. And then with the ventricular volume, people's ventricles get bigger because their brains appear to be shrinking. And that's an important consideration because they write that off in our reports, and it might just mean you're normal. So it's as I mentioned, a really difficult to quantify type of population because neurodegeneration early on can be part of that normal aging population. All right. So, with regards to normal aging, many patients get referred because they are concerned about their memory or cognition. But I want to give you a bit of a guide about what is actually considered normal as per many of the studies available. So, one of the main things that occurs as we get older is our processing speeds will drop. We rely more on feedback rather than feed forward, and that takes more time. So you need more information, for example, to reach a conclusion. That means you are going to need more time to complete tasks. And this decline is often perceived as affecting other things. For example, people may struggle to find the right word, for example, and we'll talk about that in a sec. But that's not actually predominantly a language problem. It might just be that their processing speeds are dropping. Our episodic memory, which is the memory that we have for personal and recent experiences, also is quite age sensitive. Um, what you ate for dinner or the exact details of a short story, this is actually fairly age sensitive and does decline with age. Um, and may manifest as people walking into a room, for example, and kind of forgetting what they want or feeling like they can't remember more recent events, particularly if they're unimportant, like very minute, minor details. And then, as I mentioned, there is an impact on verbal fluency. So we call that the tip of the tongue phenomenon, where people, this is universally experienced. People feel like they know what the word that they want to is, and in that time, it's like imminent that you want to find it, but and you know exactly what the context is with regards to that word, but you can't just say it. And then sometimes it comes back, and sometimes it doesn't. This is likely related, as I mentioned, to the slower processing speed rather than to actual problems with language processing itself or a language problem. But that's something that often comes up. So some of those things are actually quite common with normal aging. People can start to notice them in their 50s or 60s. But if that is the extent of it, is actually something that's quite reassuring. There is a few like kind of studies that look at this, and I won't dwell too much on this because it's kind of too much neuroscience to be honest. But there are certain concepts with regards to cognitive reserve, which is basically the amount of almost like the amount of ability to sort of resist and what you build up in order to last you for later on, and then the processes that you do implement in order to build up your reserve are brain maintenance, and then compensation is how your brain is going to find a way to build up more reserve if it's going to go through something such as an injury or other risk factors. Your cognitive reserve is probably a factor of both biological things, such as biological factors like your genetics, and environmental factors like lifestyle, and that brain maintenance is basically what you're doing over time to maintain that. And then the compensation is how you're correcting for some issues. And that is how we are all sort of different from that perspective. And that's why people seem to age in different ways, right? Or seem cognitively to be different at different ages. For example, no two 80-year-olds, for example, are quite exactly the same, if that makes sense. So that's a little bit about normal aging. There are some reassuring bits about it. We are all kind of in decline, in a kind of a reassuring way. Um, but now I want to talk a little bit about the slightly heftier part of this introduction, which is approaching somebody who is cognitively impaired, and getting the information needed to accurately make a diagnosis if there is one. So, with regards to not normal, well, that's actually better appreciated than normal, which is a funny. Mild cognitive impairment is a condition in which an individual has impaired cognition, but it does not significantly impair their abilities to complete everyday tasks, which are what they need to do to complete activities of daily living and instrumental activities of daily living, as corroborated by somebody who knows this person. The cognitive domain that is affected most with regards to the cognitive impairment, we're able to divide mild cognitive impairment into two types. If the main concern and the main domain that is involved is memory, we call that amnestic mild cognitive impairment. And non-amnestic is impairment in any other cognitive domain, which we'll talk about in a sec, outside of the memory. And sometimes amnestic MCI or amnestic mild cognitive impairment begins to involve other domains. And that at that point, it's going to be, is it primarily amnestic in the beginning or later on? That differentiation becomes kind of moot and useless after a while. For many people, MCI is important to identify because MCI is a transition state towards a diagnosis of major cognitive impairment or dementia. Obviously, for people who have had MCI previously or a formal diagnosis of MCI, they are 2.8 times at risk of developing dementia. That being said, the outcomes of patients with MCI are not universal. About 25% of them followed over time can actually revert back to normal cognitive functioning. And that's actually a really important thing for us to highlight. Some of the factors or the risk factors that help us determine who is going to progress towards a major cognitive impairment or dementia diagnosis when they've had mild cognitive impairment, um, is whether or not the MCI is amnestic. Plus, there's one additional cognitive domain that's involved, whether it be language, executive functioning, attention, etc. When you have multi-domain MCI, we think that the presence of certain neuropsychiatric symptoms, particularly depression, um, at the same time of the diagnosis of MCI or beforehand may actually herald a greater risk of progressing to a dementia diagnosis. And then there is a big question mark that for with regards to whether vascular risk factors in the context of MCI themselves are the cause for progression, because as we'll see later on, vascular risk factors are certainly risk factors for dementia. That's universally agreed on, but do they actually lead to progression themselves? Um, so this is just a little graphic here, just demonstrating what MCI looks like. Memory is the one that's predominantly impacted with amnestic MCI, whereas it's not impacted with non-amnestic MCI. And then other domains may or may not be involved, as you can see. Dementia or major cognitive impairment or major neurocognitive disorder, as defined by the DSM, is also what we use in neurology as evidence from the history and the clinical assessment that indicates that there is an impairment in specific cognitive domains, and it has to impact at least one domain. They have learning and memory. Not exactly sure what the DSM meant by learning here, but basically the memory domain, the language domain, executive functioning, complex attention, perceptual motor functions, or social cognition. In neurology, we don't usually refer to domains as perceptual motor function. We typically refer to that as praxis. And then social cognition, we'll talk about that in a bit, but that's kind of social behavior or behavior in general within neurology. Um, this impairment, it has to actually represent a decline from a previous level of functioning. For example, so there are people who have a diagnoses of autism or for example, developmental disabilities that have this impairment with regards to their language or memory or functioning at a baseline. So that does not qualify as dementia. It has to represent a change, and that these things interfere now with activities of daily living where they did not with MCI or mild cognitive impairment. And this has to occur outside of a delirium, and this arises for people in hospital quite a bit. You certainly don't want to make this diagnosis in a hospital setting, particularly when there is a metabolic or infectious problem going on, because you may truly underestimate that. However, that being said, the delirium may in and of itself unmask this. And then there, of course, with any sort of diagnostic criteria, it's not accounted for by something else that better explains it, like a mental health disorder or schizophrenia, for example. Approaching it, somebody with a cognitive decline should not make you worried or scared. It's actually an invitation to get to know your patients more and to get to know the way they live their lives and their families. So you are obviously going to get a history of presenting illness. You need to know about their past medical history, medications, social history, ongoing and past use of alcohol and substances. Family history is important. You're gonna, perform a cursory neurological exam and obtain some baseline studies. What is different though about that assessment is one, self-history may not be reliable, so you might need to include a family or a partner in that assessment. You may also need to set an agenda, particularly when a patient is very much not aware of their problem. You really do need to quantify the time course because a change that occurs over the span of 1 year from functioning to really not functioning is a totally different differential from somebody who has been noticing issues for more than a year that has and things have been progressing insidiously and slowly. You want to screen you want to quantify the deficit and the pattern. This is important because as we talked about, MCI is amnestic or non-amnestic, and then you want to quantify which domains are impacted here. And that's where the bedside testing and exam and mental status examination comes in with some of the available tools. And then screening for confounding conditions is really important in this case as well. Your lab tests are not a must. You're not really going to diagnose cognitive impairment via lab test, but you are going to exclude important etiologies prior to thinking about referral. And then neuroimaging also plays a really important role, and establishing safety is also something that's going to come into that social history piece. Now, this is something I do for myself, and I think that it just helps guide me towards what I would like to ask during the appointment, but I have a much simplified version coming. But in summary, the domains actually correspond to specific networks and areas in the brain. They're not truly specific areas. Although, as you all know, most of our language from an expressive perspective is in our left hemisphere for right-handed people, and it's localized within the inferior frontal lobe and the superior temporal areas. But I think that it's important to understand that those domains that we're testing for and thinking about are coming from specific networks or areas. So executive functioning is an important set of things that an area of the brain called the dorsolateral prefrontal cortex does. And it's involved in planning, decision making, judgment, doing things that take multiple steps like cooking, learning new skills, multitasking, and tracking your errors and correcting yourself. Um, the frontal polar cortex, so the pole is something that is really important with regards to social functioning. So the frontopolar and orbital cortices, so the area of the brain that's against the orbit of the eyes, that's where our social cues and traditions and functioning in a social setting is stored. So when that stuff is impaired, people can become very apathetic. They can become unempathetic. They can be socially and behaviorally disinhibited. They will be inappropriate. They will make crass jokes. They may also develop weird ritualistic behaviors. They may engage in, for example, obsessive or sort of not goal-directed behaviors, but like behaviors, for example, that really move with that dopamine part of our brain, for example, gambling or hypersexuality. Depression and anxiety, irritability is also believed to arise from disruption of those circuits and occasionally psychotic behavior and delusions. Memory, as we all know, is within the sort of Papez circuit in our temporal lobes. So those people have troubles with plans, repeating questions. They rely or overly rely on their notes or calendars. They lose items. They misplace things, and they have distortions where they kind of misremember events. Language is associated with word finding difficulties. Sometimes it can also lead to speech being difficult to understand because people are pausing or searching for words. Their grammar and spelling can deteriorate, reading can suffer, and sometimes people will use substitutions, either of words or syllables, to refer to things. Visuospatial domain is for navigation. This is mainly located in the inferior parietal and occipital connections, but these are people who have trouble with navigation and also kind of imagining their space in their mind. Um, and they can mistake objects or even have difficulties with recognition. And that's often the areas that are activated in the brain where visual hallucinations play a part. And as I mentioned, praxis is where you're using tools. And not to belabor this too much, the attentional domain is medially in the frontal lobe, typically the medial cingulate circuit, but those are people who are having a lot of difficulties with maintaining attention and focus. They can't really follow conversations, and they also may have a lot of apathy because the motivation part of things is sort of gone. So I typically try to draw a little brain on my sheet and ask a few questions pertaining to each domain. However, I've tried to simplify it, and we'll make this available. This is based on the Canadian Alzheimer's Society's recommended questions for primary health care providers and family doctors to ask patients who have or are presenting with a cognitive concern. So again, with regards to the memory, it's about appointments, repeating questions and misplacing things. Same thing with language, visuospatial ability, and then executive functioning and praxis. And honestly, if you ask a question in each of these domains, or even two of or three of four, I think that's at least a good screening for somebody who comes to you with that complaint. And we'll talk about like who should actually be screened. You need to develop your own approach. Unfortunately, this is it's a very personal thing, and it depends on how you approach your own patients. But I can tell you myself that you have to develop your own approach and refine it as time goes on. And the more you do it, and the more you formalize it, the easier it's going to be. Some symptoms that are important to include if you are seeing these patients or are referring them is the reports of a family member who has concerns and lives with them. Suddenly, patients having unexplained decline in their instrumental activities of daily living. If they miss their appointments with you, if they have difficulty remembering or following in the instructions that you give them, or have difficulty administering their own medications and rely on others to help remind them. Decreasing self-care, and then people falling prey to financial scams is is a really important thing. They are very, very common right now, and it's really important to pick up on this. And I've had a few patients, unfortunately, actually fall victim to this. It doesn't necessarily mean cognitive impairment. The scanners are that good. It's just something to note. And then new onset or later life behavioral changes, including if they've got depression or anxiety. I'm going to take a little bit of a detour because I know that your patients are coming to you with new symptoms of low mood or anxiety or even behavioral changes that family is potentially reporting. And this is a very helpful thing to note. We now understand that at least in my mind, I divide the world into sort of two parts. So there are the people of us who have been very anxious, for example, since they learned how to perceive the world. And then there is people who have simply just not experienced those symptoms. There are people who have had periods of dysphoria earlier on in their life, in their teens and early 20s. And then there are people who have just simply never experienced those symptoms. I want you to pay attention to the people who, after the age of 50, um, develop new onset psychiatric symptoms. We now understand that this behavioral impairment, often manifesting as neuropsychiatric symptoms, may actually be a prodromal stage prior to MCI and therefore a prodromal stage to dementia. And it's not specific to a specific cause of dementia like Alzheimer's disease, but rather can actually be associated with multiple cognitive disorders. So this is the construct of the mild behavioral impairment. This is something that has, come into vogue over the last 10 years. But mild behavioral impairment basically is this construct that it identifies a group of people who have new impactful neuropsychiatric symptoms that arise after the age of 50. And by definition, these people have not had any cognitive issues, but may actually develop those later on. And they also are not known to have generalized anxiety disorder since they were like, teenagers. Um, the symptom domains of mild behavioral impairment, I don't want to really go too deep into this, but people can complain of multiple domains, which is different from your cognitive domains, because by definition, these people's brains and cognition is totally normal, but they can have difficulties with motivation. They can have emotional dysregulation manifesting as dysphoria or depressive symptoms, new onset anxiety. It's honestly one of the most humbling things to meet a person who has never had anxiety in their whole life, who suddenly develops it out of nowhere. And it's a very interesting observation that many of those people actually progress to MCI and other neurodegenerative problems. Sometimes impulse control can be a problem that starts to arise at this age, or new behaviors. Social inappropriateness, again, from that frontopolar orbitofrontal cortex. And then sometimes people can also develop hallucinations and delusions at this age without a prior history. So mental health concerns in somebody who's never had them after the age of 50 um, should raise a little bit of a tiny bit of a spidey sense kind of alert that maybe something else is going on. These should not impact activities of daily living or instrumental activities of daily living, but they are enough probably to cause disruption for this person in their relationships, in their family life, and other social functioning, like losing friends, becoming a bit more isolated, and their workplaces, most importantly. They're maintaining their independence, though, and they are able to function and do not need much assistance. I'm going to take a little historical tangent and talk about August Dieter, who is basically patient zero for Dr. Alois Alzheimer, who was a German neurologist. I mean, psychiatrist possibly also. But what her actual presentation was with behavioral impairment. This is a woman who was a seamstress, a mother of three, who was supporting her family, and who was married. And her first presentation was actually with a year-long obsession where she experienced delusions of infidelity, where she kept accusing her very loyal husband, who continued to care for her up until her death, of infidelity. And then began experiencing the cognitive symptoms where she became very forgetful and had difficulties with visuospatial function, and then progressed on to having the symptoms that we now classically identify as Alzheimer's disease. She went into the facility that Dr. Alzheimer practiced in, and her husband actually continued to visit her and care for her up until the end. And but potentially unethical thing that happened was that they couldn't actually afford her staying in that hospital, but in exchange for her brain and for continued follow-up, Dr. Alzheimer allowed her to stay in that facility, and her care was not transferred over. So just a very interesting episode. So those with those first psychiatric episodes later in life should be assessed for a psychiatric condition, but you have a higher index of suspicion that maybe something else is going on. This is just a little bit of a tidbit about, what I would review from a symptom perspective with regards to patients who are presenting with cognitive concerns. The top three for confounders or comorbidities are really important, and these are things that I've come across in my clinic. So the daily cannabis user has shown up in my clinic with cognitive concerns, and thankfully has felt much better after stopping their 4 CBD joints. Patients who have ongoing psychiatric disorders, as we mentioned, and those with untreated sleep apnea. It's important also to know if these patients have had strokes before or if they are potentially drinking more alcohol than they're disclosing. And then on their physical examinations, it's important to figure out if there's any other major abnormalities, like, for example, fluctuating levels of alertness or consciousness, visual hallucinations, acting out dreams, which is indicative of REM sleep behavioral disorder, which is part of the prodrome for neurodegenerative problems like dementia with Lewy bodies. Tremor, poor balance and falls, rigidity and weakness are all sort of signs of neurodegeneration and Parkinsonism. So those are nice things to pick up on in the review of that cognitive patient. Just a quick note about obstructive sleep apnea and cognition, because I actually do diagnose this not infrequently for patients who are quite a bit younger than the usual cognitive impairment patient population. I do see still referrals for patients who are in their late 40s, for example, who are concerned about their memory, and it actually ends up being just really severe untreated sleep apnea that once a CPAP or the oral device is instituted, those cognitive concerns improve. So it's actually known that fragmented sleep as well as obstructive sleep apnea in and of itself is a risk factor with regards to cognitive impairment. How much, though, is difficult to quantify. And is it an isolated risk factor? Is it because it worsens other vascular risk factors? But yes, it's still difficult to quantify the exact role. But we know that the hypoxia, the inflammatory changes, the autonomic activation are all very important with regards to impacting cognition. And as per the 2024 Canadian guidelines for diagnosing dementia, there is a recommendation to actually assess patients for sleep time and assess them for sleep apnea with risk factors and scores, and treat it if that is an underlying condition. Now, I'm going to touch very quickly on bedside testing, noting that we have a tiny bit of time before our break, but routine testing of asymptomatic people is not indicated and does not have any evidence to support it at this point. So that's not something I would recommend. And cognitive testing for patients is helpful to quantify and also help you understand the domains that are impacted. I put here a little comparison table for the MoCA and the mini mental state examination, just comparing both of them. My preference is the MoCA, not only just because I have longer appointments, but it's also one of those tests that actually captures more domains than the mini mental state. The mini mental state is nice and easy to administer, though. It is quite short in duration. So if you're running short on time, that's a good test to administer. It has pretty good inter-rater and reliability, but the reliability of the MoCA is better. The delayed recall on mini mental state versus the MoCA is only for 3 words, meaning it's just less of a challenge for people. And it might miss really mild memory deficits. And then in between the time for actually assessing delayed recall on the mini mental state versus the MoCA. On the MoCA, it's actually a bit more standardized because the tests between the registration task and the actual delayed recall task have a fairly consistent time that patients perform on. So that makes the interval a bit more consistent, whereas the mini mental state, it kind of depends on how much time they take for the calculation as well as the attention task, like how much time they're going to take for spelling world or serial sevens. And as I mentioned, it has less domains than mini mental. So because it doesn't have clock drawing or trail making task B, then it's not sensitive for those executive domains. And finally, the mini mental state exam is a very easy test. So for highly educated patients and patients who are already quite intelligent, there is a bit of a ceiling effect where those patients, despite cognitive impairment, may actually be able to get good scores. Whereas with the Montreal Cognitive Assessment or the MoCA, that is less likely to be the case. So that's my preference. But any of these bedside cognitive tests are very helpful in quantifying a deficit. I just want to touch on a little bit about the trail making task B. This is one of my favorite tests in all of neurology. Trail making task B implies that there is a trail making task A, and indeed there is. Trail making task A is basically a sequencing test. So it has a bunch of letters or a bunch of numbers, and it just asks the patient to connect the numbers or letters in sequence. So it'll go A to L, or 1 to I think 28 or 27. Whereas the trail making task B is the task that requires alternating letter and number. And it's a nice test because it has been found to really activate that dorsolateral prefrontal cortex and is a really great task for function of that cortex called task setting and monitoring. So you really do need to sort of remember that pattern and keep shifting your attention. And you need to monitor yourself for errors because the way that the letters are placed is also fairly intelligent. This test is really helpful because if you take a really long time in performing the test, or if you make errors in those tests, or if you do have both, so you take a long time and you make errors, this has a fairly high sensitivity and specificity for cognitive issues, particularly those impacting executive functioning. Usually the cutoff for this sensitivity is 80 seconds to complete it. I thought that was pretty short, but then I kind of thought applied that with most of my patients, but soon after explaining it, most patients will actually perform this in less than 20 seconds. So somebody who's taken a minute and a half to think about it is really struggling. And up to 3 minutes can be actually a helpful marker to identify people who might not be safe for driving, which we'll address later on. But this is a great test and something that you can even perform on a piece of paper in your own clinic. As promised, I did want us to take a bit of a break. Hopefully people can stretch their legs, get a tea or a sip of water before we sort of delve into more. And then during this period of time, hopefully I'll be able to screen some questions that have maybe come up and answer the ones that pertain to this part of the talk. and keep the other ones that I might be answering later on for later.
Hi, Dana. We have a couple of questions. Um, is there a specific way to differentiate MBI from menopause-related symptoms or hormone change related to recent use of hormones in younger population? Oh, you're muted.
That's a really good question. Yeah. Yeah, that's a good one. And okay, how do you score if they start the trail from two? Okay, that's a good one as well.
It was just those two for now.
Okay, perfect. Shall I answer those when we're sort of back from our break then?
Sure.
Good. So I thought maybe like about a 5 minute break and then we'll come back and touch on those.
Okay.
Hopefully the echo was not coming from me. Was it coming from me?
No, I think we got that sorted.
Okay, because I couldn't hear an echo. Everything was okay on my end.
Okay, good. So did you want a 5 minute break, Dr. Danah?
Yeah, let's just maybe get a 5 minute break. Everybody hopefully gets to stretch their legs and get themselves a nice tea and uh, use the washroom if you need to. I know it's a kind of after a work day type of lecture and can be a pretty heavy material. So uh, maybe we'll come back in 5 minutes and go from there.
Sounds good. So we'll come
All
back
right.
at 7 o'clock for everybody on the line. And if you have some questions percolating over the break, please feel free to pop them in the chat. We'll see you guys in a couple minutes.
Hi, Dana, are you there? Okay. Is it all right if I share my screen with the questions now, Dana? Okay.
Yeah, perfect. And I'll just stop sharing, right?
Yes. Here we go. Can you see my screen?
Mm-hmm. Perfect. Okay. All right. So the first question is about differentiating mild behavioral impairment from menopause-related symptoms or hormonal changes. And that's actually a really good question. Long and short of it is we probably do not understand the cognitive profiles of women going through menopause. And we have not quantified specific behavioral changes associated with that on a large scale. That being said, I would say that the um, typical domains that are involved in mild behavioral impairment, um, they don't typically like meet the sort of threshold for uh, just like a psychiatric disorder, but they are also specifically more to do with the sort of motivational part of the nervous system. So it's more like motivation related deficits. In addition to the fact that these patients may develop anxiety from a baseline of having sort of no anxiety, for example, somebody who's been anxious for a long time, for example, having an increase in their anxiety from a situational perspective, that's probably a clue that it's not mild behavioral impairment. And then typically the sort of dysphoria associated with mild behavioral impairment. Again, it doesn't meet criteria for depression, and oftentimes, yeah, if it sounds like depression and smells like depression, and then it's probably depression. But it's just something to note in a person who has sort of gone uh, from a baseline of not having these symptoms to having them. I think the construct is also really important for people who are going to go on to develop other dementias, like, for example, frontotemporal dementia. That sort of dementia is especially the most common variant of it, behavioral frontotemporal dementia. Those patients they gradually lose their social graces. And that's where also the MBI concept is very helpful. It is very difficult to differentiate it specifically from hormonal changes, but I would say that it's a totally new symptom in a baseline for somebody who's never had it. In addition to the fact that it is not simply related to or associated with the symptoms of menopause at that time. With regards to scoring the trail making, well, on the MOCA, the trail making actually starts at 2. So they've already established the pattern for you, so they make it even easier, and you score it exactly as you would. In the MOCA, it is worth just 1 point, but observing how somebody performs trail making and how much time they take to do it is a really helpful tool, as well as how many errors they're making. So I always make note of how many errors they're making. So, for example, if they've like connected a number to a letter, and then a number and then went to the like wrong, like the next number that's correct in the sequence, and then connected the number to a number, then are they going to resume and find their way back, or are they not? So it's just the number of errors that people are making. Um, so yeah, it depends on what sheet you're using, but it typically on the Mocha it starts from 2. I usually tell people they've already established the pattern here. It's an alternating pattern of an ascending and alternating pattern of number, letter, number, letter. They've already done the 1 to A for you, or A to 1 or whatever it is, starting with number 2. Where would you connect this following the same pattern? The 6-CIT is used in Canada. There's a million different dementia tools. Most dementia trials actually use something called the CDR, which is like a structured sort of interview with the patient and their family member. So use whatever you're comfortable with and is available to you. But I think it's absolutely based on whatever you're comfortable with, as long as you're quantifying things. Difference between Parkinson's disease and Parkinsonism. It's a slightly out of the scope of this, but I'll tell you. So, Parkinsonism is a syndrome. It is not a it is not a like a specific diagnosis. Parkinsonism, by definition, the patient has to have a core feature, which is bradykinesia, which is a reduction in the speed and amplitude of a movement that is repetitive with interruptions in that movement. So that's a core feature. And then with the bradykinesia, you need one of two things, either of them. Both okay, but either of them. So the things that you need to make a diagnosis of Parkinsonism in the context of bradykinesia is either a tremor, which has the characteristics of a Parkinsonian tremor, typically at rest as the biggest component, or rigidity, which is a resistance to the passive range of movement when a joint is moved. So that is a big umbrella term for a lot of disorders that can have Parkinsonism as part of their symptoms. Parkinson's disease, or idiopathic Parkinson's disease as we know it, is the most common cause of Parkinsonism in the world. That being said, there's other disorders that have Parkinsonism as part of their symptomology, but also have other features that make them not idiopathic Parkinson's disease. You may have heard of dementia with Lewy bodies or dementia with Lewy bodies or PSP, which is progressive supranuclear palsy, MSA, multiple system atrophy. Parkinsonism can also be a syndrome that happens when people get specific insults to their brain, like certain strokes can cause vascular Parkinsonism. So it's just an umbrella term, and Parkinson's disease is a cause of it. Same thing with dementia. Dementia is the umbrella term for the syndrome of major neurocognitive impairment. Alzheimer's disease is one of the etiologies, or Alzheimer's dementia is one of the etiologies. Okay. No, I would not suggest imaging for most menopause, for patients who are experiencing symptoms that are related to menopause or hormone use. I would only suggest imaging if patients have a quantifiable cognitive impairment. Sorry, the MOCA, yes, does tell you to start from 1 to 8, but when people just start from the 2, kind of following with, if they've put their pen and they've kind of just followed it and then they've made no further errors, that's a complete score in my book. Okay. Shall we return to the rest of this? I will try to share my screen again. Okay, so we're done our break. And next, I wanted to talk through a case because this is a case that's actually mine. This is my patient who is possibly referred to me by one of you. I have changed all the information, but the age of the patient and everything else other than their name is correct. So this is Cheryl. She is 57, and she is a person who's been referred to the neurology clinic for cognitive decline. She came to the appointment with her partner, whose name is John, and she has a past medical history of dyslipidemia found on just regular screening. She's on rosuvastatin 5 milligrams once daily. She works with kids as an early education worker. She has more than 12 years of formal education. She has a bachelor degree in education. She's never smoked and does not drink alcohol in excess, and actually currently does not drink and doesn't use any recreational drugs. And she has a class 5 driver's license like the rest of us who have a regular license. She began having issues at work over the past 2 years. She's now currently working part-time, but previously was working full-time around a year ago. Her duties at work are that she goes into the day home where she works, and she actually opens it up for the day, and then she receives the children and cares for them there. She began making some mistakes where uh, once she let a child go with a adult who was not their parent, thankfully it was not serious. It was actually just a family friend who was picking them up with their kid and mixing up the kids' belongings. And she began having major issues, and actually that's why she switched to the part-time job when the company decided that they wanted to have like this app that they use to sort of track the drop-offs and the pickup times for parents. And no matter how many times she tried with IT, she just couldn't grasp the app. So she's been struggling with that. Over the last 5 years, she's lost her credit card 3 times and also has left it at a store. She really stopped going or driving to Costco because every time she was there, she would lose her car in the parking lot and at times spent up to an hour actually looking for it. Although she's remained a very safe driver, she has not had any speeding tickets or accidents, and sticks to driving into familiar locations. So just tries to avoid anything unfamiliar. She has had some word finding difficulties, and in fact, her um, husband, John, tells us that she has been relying a lot on phone dictation, like the little dictation in her iPhone, because she's making some spelling mistakes, which has never been the case for her. And John has been managing all of their finances their whole life, so she's not had any issues there. Um, I wanted to show you her mocha, and you can see here that she has started or began to do the trail making task B, but was not able to complete it. She really struggled with the cube, had to trace it and then tried to draw it on her own. And then with regards to the placement of the numbers on the clock. Obviously, she put the 10 and the 11 sort of before the 12 and really was not able to put the hands of the clock on there. And then with regards to the remainder of her testing, she had difficulties um, with the repetition tasks or the registration tasks. She had very, very normal and preserved phonemic verbal fluency and had some trouble with abstraction with the train and the bicycle. The common incorrect answer is to say that they both have wheels instead of saying their modes of transportation. And then the same thing with the watch and ruler. People will say they have numbers. And then had just missed 1 point for orientation, but lost all of the points for delayed recall. And you can see here the MIS is she's actually had no ability to recall the words without actually having to pick them out of a multiple choice list. So that's it was a score of 13 out of 30. Wanted to show you her scan. So this is just an axial cut of a flare sequence of an MRI that I ordered for her. And overall, you could see gray-white matter differentiation is well preserved. And overall, there is no areas of brightness that we're worried about on the flare scan. And this is just a coronal sequence of the same brain. Now, this is reversed because it's a T1 where things are more anatomical. The impression is that this is an unremarkable MRI of the brain. However, my interpretation of it, and you might be able to see that as well, is that actually there is a bit more atrophy, particularly around the back part of the brain and the parietal lobes. And the reason I like this coronal cut is you can see that there is quite a large gaps with regards to her sulci and gyri, and some of her gyri are quite thin near the top here. So that's why it's important to be able to look at our own scans, and that enables us to make these differentiations. And this is unfortunately something that is not incredibly accessible to primary care practitioners or to even some practitioners in the community. So it's really important that we actually are able to look at those. So this is my patient Cheryl, who has a diagnosis of Alzheimer's disease. I wanted to talk a little bit about that because this is the most prevalent sort of dementia that we experience and see in practice. And this is something that no healthcare worker is going to go through their career without seeing, unless they're maybe, I mean, even pathologists see it, right? Because they do neuropathology. But Alzheimer's disease is a neurodegenerative disorder. It typically starts out as a amnestic problem and then begins to involve other parts of the brain. The pathology includes these senile plaques and neurofibrillary tangles, first described by in that initial patient I showed you. About up to 10% of the population has or will develop Alzheimer's disease, so that's a huge percentage. And 2/3 of those patients are women. So that's a very important risk factor that people may not be aware of. Alzheimer's disease occurs more frequently in women. Um, the average patient with Alzheimer's disease will live somewhere between 4 to 8 years, but can be up to 12 years with regards to range. And it's very difficult for us to tell that component of it. So a bit about the pathology, because it's going to become important as we talk about testing, where now there's tests available and we need to know about judiciously ordering them. So the plaques of Alzheimer's disease, they're made out of protein called beta amyloid, which is often abbreviated A beta. This has either a 40 or a 42 amino acid like peptide, and it's actually usually it's a normal protein part of our body, but it misfolds, and that is how it becomes insoluble. These plaques are mostly of the A beta 42 variant rather than the A beta 40. And they are extracellular, so they're outside the cells, and they almost are sedimented there, and they impact neural cells as well as glial cells. The tangles are made out of a protein called tau. This is also a normal protein. It's part of our microtubule, like sort of cytoskeleton structure, and it's usually completely water soluble and is not visible. But when it becomes a tangle, it is usually hyperphosphorylated, and then it goes inside the cell. When the neuron dies, the tangles are sort of left behind like little ghosts. And those were the classical findings that were found on that initial pathology. We don't know at all, or to a great extent, exactly how these plaques and these tangles actually lead to cognitive decline, and what is the sort of incipient event that leads to the tangles and the plaques forming. It occurs in this weird sequential manner. Usually it starts in the cortex, and then it goes into the hippocampus, and then it goes into the basal ganglia and the thalamus. And it almost like infects other areas of the brain. And we see that also in other problems like Parkinson's disease. They do impact neurotransmitters, and we'll talk about why acetylcholine is an important one, but that's typically the preclinical stage is really just certain areas of the cortex, and then the hippocampus, and then it begins to involve the remainder of the neocortex. Female sex and age are basically some of the most important risk factors, but as you can see, like with increasing age, we start to see more and more patients, and then there's about 37 cases for everybody for 1,000 patients who are over the age of 80. MCI, the mild cognitive impairment, is more common in men, but the prevalence of the actual confirmed Alzheimer's disease dementia is more common in women, which is pretty interesting. Hypertension is a huge risk factor for Alzheimer's disease specifically, and for dementia in general. It is particularly in midlife. It carries a rate of at a rate of 1.61, and then it can for each drop in the systolic BP, you do help patients reduce the risk of mild cognitive impairment by approximately 19%. So this is a huge opportunity as primary care, not only to treat patients from hypertension for heart disease and strokes, but also because it also literally does impact dementia risk. I really like this graph that the Lancet released. They release every few years a sort of compounded and weighted risk score for things that do lead to dementia. And when people ask me what they can do to help avoid that, this is what I have actually printed in my clinic and what I give them. So in early life, we know that less education is a risk factor. In midlife, very surprisingly, hearing loss is one of the most important things to treat and to identify. Following that, you have all the traditional vascular risk factors, which include, high cholesterol, hypertension, obesity, smoking, and excessive alcohol use, as well as a history of traumatic brain injury and depression. As we mentioned, depression with MCI is an important risk factor for progression. And then late life, people who are isolated and who have visual loss. And this compounds to about 45% of the modifiable components for dementia. So I think this is a really helpful thing to give to the patient who's curious and is asking what they can do to maintain brain health. Really, it's honestly hearing loss is such an important thing to treat, and I think there's such a stigma against it. Is there a role for your genetics? Certainly. The typically there is a small proportion of patients who can have an autosomal dominant form of the disease. This is thankfully rare and is uncommon. There's sort of 3 genes that are implicated in this. ApoE allele status helps us understand the risk associated with Alzheimer's disease, and that's something that'll come up in testing in a bit. But this is the status of their allele is a very important risk factor. Now, up until recently, this was not commercially available, but more recently it is, and you might get patients who are asking you about it. Does it really matter if a person's mom or dad was diagnosed with dementia or Alzheimer's dementia? Well, possibly. The overall risk of Alzheimer's disease for people between 65 and 70 is about 2.5%. So if you didn't have the family history, that risk is 1.5%. And if you had the family history, you're probably closer to that 3%. So certainly it does confer a bit of a risk, but is that risk so substantial as outside of the people who have like an autosomal dominant gene that produces Alzheimer's disease? Probably not much to worry about, as most cases are sporadic. The typical presentation, as we all probably know at this point, is cognitive deficits, with the short-term memory and episodic memory being the first to go. And these patients start to repeat questions and comments. They frequently misplace things. Their long-term memories are totally fine. And they can have some impaired learning because they require those. And that's what the case with my patient, where she was really struggling to grasp this new app. And they also have often quite significant visuospatial abnormalities, as well as some language deficits. They can have psychiatric features, as we mentioned, with mild behavioral impairment. During the diagnosis, they may also experience coexisting psychiatric diagnoses or behavioral impairment, and also late in the disease. Sometimes they'll have motor symptoms like rigidity or it's not truly a rigidity, it's called more like paratonia, where the patient really fails to relax. They can also have gait changes and changes in their stride length. And then in terminal stages, when patients are very advanced, we see seizures, we see myoclonus and incontinence, as well as sometimes akinetic mutism. The MRI is basically one of the best ways to evaluate the anatomy, but a CT scan may actually be just enough. Brain imaging is helpful, honestly, mostly to exclude pathologies rather than to confirm a diagnosis. The atrophy that we see in a brain lags behind the onset of cognitive symptoms by at times years, and you can still make a diagnosis of a dementia in somebody whose brain anatomically looks quite normal on a scan. So it's mostly to exclude things like subdural hemorrhages, masses, or very severe cerebrovascular disease or strokes. But it can also be helpful, just like with my patient, where we saw that pattern of biparietal atrophy. Temporal lobe atrophy is what we think about classically with Alzheimer's disease, but also atrophy in the parietal lobes is actually quite common, and that's probably what explains the visuospatial difficulties. We don't have this in BC as of yet, but PET scans can also be really helpful, and it's as expected, those areas in the parietal lobes and the temporal lobes that are not functioning won't take up the FDG. And you can see here in the imaging follow-up for a patient where the hippocampus is clearly seen, and then it starts to really atrophy, and you can see those ventricles getting quite a bit bigger and the loss of the white and gray matter over time. You might have heard of fluid biomarkers for Alzheimer's disease. Well, there is now, unlike literally when I graduated from med school in 2016, an ability to actually diagnose with certainty Alzheimer's disease during people's lives. Back in med school, which is hopefully not that long ago for me, but about 10 years, we definitely relied heavily on clinical characterization and sort of follow-up, and it was mostly a diagnosis that was only going to be proven pathologically and inferred from imaging possibly, and then it was sort of, that's it. A lot of time and energy has gone into actually identifying those biomarkers, and now we are actually able to test for them. We are able to, in BC, test for in specialized clinics. So like I order these tests, and any neurologist is able to do this if they choose to. Order the actual levels of A beta 42 amyloid protein. We actually usually use a ratio when the result comes out. And then we also calculate a ratio for how much tau is in there in the CSF. They have very high sensitivity and specificity, and it's not recommended routinely, but for somebody who is experiencing these symptoms who wishes to get confirmation, this is really helpful. It also is helpful now for us to shift our perspective a little bit for patients, because despite there not being anything imminently curative for them, certainty is such an important part of knowing what's happening to you, and the uncertainty is what causes a lot of distress for people. So I think that this, even if it has not ultimately changed management for people, it's just such a helpful thing to be able to tell people with certainty, hey, it is actually Alzheimer's disease, and it allows people to plan accordingly. You might have seen that there is a LifeLab Rex that has been potentially floating around. They are offering some private pay testing for some biomarkers. The ones that they have available, I believe, are the tau 217. So this has been shown in meta-analyses to have a high sensitivity and specificity. It varies, though, by age and disease severity. And most of the populations studied here are Caucasian populations. So we don't really have validated measures for serum, for serology for patients who are, for example, non-Caucasian, Black, South Asian, or other ethnicities. So we do not know if this data is immediately translates. Just like in the CSF, they are also offering a ratio, which is the A beta amyloid 42 to 40 ratio. this is done through this immunoprecipitation mass spectrometry sort of testing, and it can be helpful even in very early disease, but it can also be affected by inflammation, or if somebody has renal problems or has low albumin levels, as well as what their ApoE genotype is. And there's also I don't know if they're offering, they are actually offering this. This is the 181 tau, has strong correlations with the cerebrospinal fluid. Again, it may have a role in predicting progression, but these are now something that patients may actually bring to your attention, and it's helpful to know what they're for and some of the limitations associated with them. I mentioned the EPOA subtypes because that's also available on the testing. You can actually see it as a second test here. ApoE is a normal part of our protein structure and participates in the cholesterol sort of chylomicron and LDL shape and molecule. People can either have epsilon 4 or epsilon 2, and you can be homozygotic or heterozygotic for it. But essentially, it's one of the most very important and strong genetic risk factors for Alzheimer's disease. And it also increases the rate of deposition of A beta amyloid in blood vessels. So for people who are homozygotes, it's about a 10 times lifetime risk. For people who are heterozygotes, it's maybe 2 to 3 times. And if you have the epsilon E subtype, then you have the sort of lowest risk. But that's what technically those tests are meant to. So this is not a direct test of Alzheimer's disease. This is sort of a test of your genetic risk for it. But this is not a gene that actually causes Alzheimer's disease or is associated with it, because there's other genes that can do that. Now, do you order it or do you not order it? The big conundrum that comes up for us. These biomarkers, they are probably a very powerful tool for advancing their care, but there is a lot of ethical and concerns about effective widespread use. Does this, again, include patients who are of different populations? Are their results going to be similar to similar cutoff points? What is the utility of these results without clinical correlation? So this is just somebody who went to the lab and got the result without a consistent or concerning clinical syndrome. What are the cutoffs that our labs are using in comparison to what studies are using? How do you disclose the results of these tests? And is it going to cause excess distress or anxiety, or is it going to lead to stigma? There are also implications from an insurance perspective or an employment perspective. So for somebody who might have this, but has no significant cognitive impairment, who is at a potentially high risk sort of position, like a pilot or a surgeon, is that going to be something that impacts their employment? And whether or not they'll be able to get a life insurance payout, for example, or a disability payment. I do not recommend the use of the serum biomarkers. I think that they can be helpful after a diagnosis of mild cognitive impairment or dementia is used, and I would say that I would use these as probably as negative predictive tools rather than anything like that. But I would say proceed with caution, because I think this is a really tricky area where and the frankly, like, I think even within the pool of neurologists, there might not be expertise in interpreting these results, even should you contact the expert, right? Because we're not all cognitive neurologists, and cognitive and behavioral neurology has become quite complicated. All right, so some management strategies. I wanted to talk very briefly about acetylcholinesterase inhibitors. I want to leave a robust amount of time for questions and maybe get us all out of back home or back to our families in a reasonable amount of time. But because there is a belief that some of the earliest neurons involved are the acetylcholinesterase neurons in the brain in those early cortical areas, then we think that inhibiting acetylcholinesterase will increase the acetylcholine in the brain and therefore can serve as a symptomatic treatment for Alzheimer's disease's core cognitive concerns as well as the behavioral concerns. Donepezil is the one that we use for all stages, and rivastigmine has also been approved for patients with Parkinson's-related disorders. And I would argue that people with Parkinsonism with dementia might actually improve more on these medications than people with Alzheimer's disease. And this is typically something that is usually fairly well tolerated. I typically start it at 5 milligrams at bedtime, and then you can increase it to the next dose, which is 10 milligrams. Oftentimes, I warn people or get an EKG right before I initiate donepezil because occasionally it can actually cause bradycardia and conduction abnormalities. It's important to warn patients that it can, oh, sorry, it actually should say vivid dreams, but it can also cause fairly significant GI symptoms. And if people experience diarrhea, then that is often a reason actually to stop the drug because it can be fairly severe. Memantine is another one of those medications that targets NMDA receptors in the brain. It's approved for moderate to severe Alzheimer's disease, and I find it's underused probably, but it can also help stabilize some of the symptoms, but does have not insignificant side effects. I think donepezil is probably something that some family physicians and primary care practitioners are a bit more comfortable with initiating, but I would go I would go very slowly with it, and you might not, immediately notice a difference in your own patient yourself, but from anecdotal experience, and obviously this has been quantified on testing, it does really help. So other things that arise, and this is again a really big topic, the treatment of some of the psychiatric symptoms that arise in Alzheimer's disease and other dementias, but it's really important to treat coexisting depression. It actually leads to worse outcomes. For that, SSRIs are preferred. Avoiding TCAs of this population is a good idea because they tend to be older, comorbid cardiac problems, and the anticholinergic effects of tricyclic antidepressants can actually make cognition worse. So again, it's a bit of a acetylcholine deficiency, so maybe don't give them the tricyclic antidepressant. Some behaviors may be helped by initiating medications like donepezil. But you also want to just keep a higher index of suspicion. Is this person's symptomology now worse because they are going through a medical condition? At that point, it is a vulnerable brain, and it might be reacting to the environment it's in. We typically don't treat hallucinations that are tolerable to the patient and not scary. But if they are, then that's something that we want to try treating. Brexpiprazole has actually been approved specifically for neuropsychiatric symptoms associated with dementia. Unfortunately, it is quite expensive, and I don't believe it's actually on the Fair Pharmacare formulary. So this will have to come out of a payment plan. But oftentimes we need low doses of risperidone, olanzapine, and quetiapine to manage psychosis and agitation, and occasionally wandering behaviors. Those obviously come with that black box warning of excess mortality, but in an informed consent setting can be very helpful. On the horizons, you might have heard in October that Health Canada has actually approved one of the first anti-amyloid monoclonal antibodies, which is lecanemab. In the US, it costs $26,000. We do not know its cost yet in Canada, but provinces and federally, they are working on it. Territorial drug plans are most likely going to be the providers for this because drug plans will, I think, simply not be enough. The sheer monitoring of this medication, because patients actually require close monitoring with sequential MRIs, may in and of itself be too costly for the public healthcare system without robust investment and infrastructure. And there is a multidisciplinary group of dementia experts that is working at the level of the country to try to determine how the medication can be made available and to whom and what that criteria is like. But that is on the horizon, and it is a huge next step because these medications have been submitted to Health Canada for approval for over a year. All right, the last bit here is a little bit about safety. There is, I want to say, no specific consensus about the safety of a patient with regards to driving. No single test is diagnostic. However, I would like to empower primary care practitioners and family doctors to raise this concern with patients and also, as per the CMA, err on the side of reporting anybody that you think may be unsafe to drive. So going back to my patient, Cheryl, her difficulties with trail making, clock drawing, and overall low score on the MOCA, but in general, her difficulties at home and the fact that she kept losing her car in parking lots made me feel like she would be an unsafe driver, despite the fact that she has not had any accidents or speeding tickets. So during that visit, I actually advised her to not drive anymore, and she has not been driving since. Is that, from my perspective, my duty is first to her for her safety, but also the public safety. We do not make decisions about whether or not patients can or cannot drive. We only alert driver fitness about condition, and they are the ones who actually determine whether or not the patient is fit to maintain the license or not. So this is something that, particularly for patients who, are either fairly impulsive or I know it's truly the worst time in the neurology clinic when you have to discuss driving with a patient. And I would say that 99% of patients are actually quite reasonable and understand the implications. However, this is a really important thing to address. I would often encourage people to ask themselves if, based on your assessment and interaction with the patient, would you feel safe letting your child or loved one sit with them in the car? And if the answer to that is, I don't think so, then we have a duty here to err on the side of safety rather than to allow that person to drive. So I just want to empower you. You are actually quite protected from this perspective. And if there is any concerns, then driver fitness can actually offer the patient a road assessment, and then that is completely out of your hands. So these are the BC guidelines. And sometimes it's not it shouldn't be something that is just based on a score. But there has been some studies that have actually looked at trail making task B specifically, which mentions that if a patient takes more than 3 minutes to complete that task or has more than 3 errors, that there is a high likelihood that this is an unsafe driver who should be advised not to drive. Hopefully, I've left ample time for questions, and I hope this was not too heavy. I had hoped that we could do this in person and I can meet people. But I hope this was helpful and maybe answered some of those questions that were already submitted. And if not, I'm happy to take any more questions.
Here is the questions that we compiled, Danah.
Sounds good. Should I stop sharing, Prob?
Yeah, you can click stop share.
Perfect. Okay. HRT, is that hormone replacement therapy? I will assume that's the case. So hormone replacement therapy is not specifically indicated to treat dementia. Um, there's also no robust body of evidence that I've been able to find, as I'm preparing something different for menopause and sort of migraine, but I haven't really found a robust body of evidence that supports the use of HRT in the management of neurological disorder. Uh, but certainly patients who are going through menopause may experience very significant psychological and cognitive symptoms that can be alleviated by the HRT. But we also know that there's risks associated with that. So I would say that, focusing on the menopause part of things is really important, but then identifying those patients who seem to have a bit more than that, and who are not responding appropriately to the HRT for menopause maybe a role. Okay. Recent research stating that statins improves the dementia progression. I totally agree with this. Statins actually have like a lot of really interesting in vivo research, and I don't really know why they are so demonized, at least in my stroke prevention clinic. They are so deeply demonized, but statins have a lot of anti-inflammatory characteristics, in addition to the fact that they also most likely address the one of those risk factors that you might have seen on the Lancet sheet, which is one of the bigger risk factors, which is dyslipidemia or hyperlipidemia. So this is probably the mechanism by which they do that, but they also certainly do have many anti-inflammatory characteristics and may indirectly help with that. So yeah, I'm a big fan of statins. I know they are globally hated, but I actually think that they are very good medications. Um, Newer meds for Alzheimer's disease or dementia. So that's the latest that we have in Canada is lecanemab. In the US, there is a donanemab. There was a prior medication that came out in 2023, which was called aducanumab. This has been taken off the market in the US also. So the two that are available now are donanemab, which we don't have yet. We don't have approval in Canada. And lecanemab, which has been approved in Canada, but we still don't have access to it from outside of research settings. So those are monoclonal antibodies that bind to the amyloid and clear it. Now, there has been so much controversy about this. You might have heard of FDA people quitting their jobs in the States because of this. But the reason for that is the controversy is they were not sure if reducing the amyloid in the brain actually helped with cognition. Now, the meta-analyses show that there is some effect. It is a small effect, though. And that's, I think, why Health Canada has a lot of hesitancy about making these drugs available because their effect sizes are fairly small and they are also very expensive medications. Okay. If patients would like to do the genetic testing, the life labs, which one is the most valuable? With regards to I would say that I would recommend not ordering the tests through life labs unless the patient actually has quantifiable either mild cognitive impairment or actual cognitive impairment. The one that I think is maybe helpful is the phosphorylated tau 217. The reason I think that test may be helpful is its negative predictive value is really high. So kind of like a Wells score for your PE, or the D-dimer for your PE rather, you're able to some extent exclude some or many dementias with a very normal T 200 phosphorylated tau 217 level. That being said, if it's high, doesn't tell you very much, right? So I would caution patients from ordering some of these ones. The genetic screening test, the only one that's available is just the risk profile for the ApoE. So that one is the only kind of genetic one of them. The rest are just kind of levels. That one confers genetic risk. But again, I caution patients from ordering those tests because, I wonder if that has implications for traveling. And I've had, many patients who did not actually want to go through with CSF testing because they thought that would impact actually their insurance or their employment. So I would caution that, but in the right context, perhaps the phosphorylated tau 217 is helpful exclusionary to exclude things for you. What is the improvement rate in patients started on donepezil? Well, the improvement rate is actually typically measured on change in their mini mental state, as well as their MOCAs, as well as sort of the reports of their interviewers, which are quantified in that CDR type of test that I mentioned. It is small. I would say in my own practice, you do see about a 10% improvement, and more than improvement, there is a potential for stabilization. And I think that's still valuable despite the effect being small. It's a rather safe medication and easy to implement. With regards to vitamin E being neuroprotective, I don't know about any like trial data or human like studies, but it is an antioxidant and potentially has a role for that. I would not prescribe. I typically, frankly, do not talk to my patients about vitamins unless they are vitamin deficient because I am very scared of patients and their vitamins. There can be a group of people who are very passionate about their vitamins. I'm sure you all have those patients. Um, that so I don't typically prescribe anything from a neuroprotective perspective. For me, the important vitamins would be vitamin B12. As a neurologist, that's something that I expect for any patient with cognitive problems. I would screen them with a vitamin B12 and replace it. A lot of people have atrophic gastritis or are on Panto or metformin, and that can impact the absorption of vitamin B12. So I make it a habit to sort of check that and replace it. And for all women, vitamin D is also important, but outside of specific contexts, I don't really recommend specific vitamins. But yeah, if families think that is something that they're interested in, I don't think I would be angry at them. And I know vitamin E is also good for nails and hair and skin, so that might be something they're interested in. Yeah, so in residential care, you're pushed to reduce meds and statins are the first to go. I think that's a really interesting question, specifically with with the effects that we know with regards to neuroprotective things. I think if we look at statins in isolation and just think about them as things that are hopefully going to reduce the risk of cardiovascular events, then oftentimes patients are pushed to come off of those because the effect of a statin in preventing a stroke is over decades. And if that person is already like 86 or 87 and suffering from fairly advanced dementia, then the effects of the statins in preventing cardiovascular disease for that specific patient is probably really low. The other part of it is as it providing like an active anti-inflammatory effect in that population. That's also hard to quantify. So I see the sort of two sides of this here. I would typically keep patients, but on the same medication, but I do reduce doses. Like for example, rosuvastatin really doesn't need to be 40 for patients who have met targets, for example, and who are elderly. Okay, any non-pharmacological management/resources role for CBD, DBT for MBI? So for non-pharmacological management and resources, the guidelines mostly speak about the need for physical activity and socially engaging activities. That is probably one of the most protective things that have been studied, whereas social isolation which probably hearing loss adds to, is a major risk factor. So the management resources, I did put some of the list of BC available resources in that PDF document. So those are helpful resources for patients and practitioners. I really love the Alzheimer's Society website, either in BC or the Alzheimer Canada website. It is so helpful. They have so many modules with regards to driving and safety and guidelines for healthcare practitioners. And I highly recommend that website. It is actually a wonderful resource. And they have a whole document and a guideline that came out in 2024 that is specifically for the management of the behavioral and psychiatric manifestations of dementia. So that's a great resource. With regards to, as a non-psychiatrist, I do not know what the roles or evidence for cognitive behavioral therapy specifically for mild behavioral impairment, just because it's one of those things that where you certainly want to treat it and address it at the time, but you're not able to sort of predict if those people are going to develop into the dementia because specifically they haven't been studied in trials for that. I do think that there is probably a role for that. And actually, it's not infrequently that I see patients already started on an SSRI or seeing a psychiatrist or a therapist for mild behavioral impairment before the cognitive symptoms start, and then they end up in neurology. So I think these are things that are absolutely worth exploring with patients and families, especially since probably causes some distress. And patients have at times certainly preserved insight and can alleviate some of these. And we know that we can treat depression in dementia, and treating depression likely indirectly prevents or reduces the risk of progressing from MCI to dementia. And it's been shown in some studies that that's the case. Okay, diet. Mediterranean diet is the diet that is recommended for patients. And there's actually in the Canadian guidelines for the diagnosis of dementia, a whole section on physical activity and diet that is so wonderful and helpful. It even goes down to the nitty-gritty where it recommends specifically how many servings of fruit and vegetables people should be including in their diet. But the Mediterranean diet is the diet that on a population level has been shown to reduce the risks of dementia. I believe that the testing through LifeLabs is not covered through MSP. So this will have to be private pay, as I mentioned. It costs, I believe, around $300. But it can also depends on how many tests you check off, because some of them can go up. I believe some of them can go up to $400 or $500 even. Maybe Elliot, you know exactly the costs per test.
Just the p-tau 217 is like $325.
Yeah. I have had a few patients who have paid for it. I believe so far that's the only one I've ordered, and I've ordered a few ApoEs for specific patients, but they are expensive and they are not covered. Again, because they're not yet going to change our management, right? We don't yet have access to those therapies. Patients who refuse to wash or bathe. That's a really big challenge. I would say that that's probably either somebody who has fairly significant behavioral disturbances as part of a dementia, which is not often in Alzheimer's disease early on, but can be part of frontotemporal dementia. And then in advanced Alzheimer's disease, these behaviors are definitely encountered. I would say that these patients often require a sort of tentative cocktail of an SSRI, low dose risperidone, occasionally acetylcholinesterase inhibitor, to just calm them enough so that they are redirectable. From that perspective, I would say medications and the expertise of healthcare workers who work with this population of patients is going to be helpful. Oftentimes, geriatric psychiatry can also have a lot of really helpful recommendations. But this is really challenging. This is the same thing when patients are aggressive or wandering, or have self-injurious behaviors. So all of those oftentimes require medication. Unfortunately, there is no proven supplement outside of, like, for patients who are vitamin B12 deficient, that is shown to improve cognition or to help patients who develop this. I often try to tell people that this is much more complex than something that can be easily treated with a supplement. We still, unfortunately, don't really even understand how exactly the amyloid plaques and the tangles themselves bring about neuronal death, and also how they actually bring about cognitive impairment. So this is a field that is still in its, even though it feels like we've been researching dementia as long as I and many of us have been alive, it's just a field that is still very much, it's still an ocean. But I think people often ask that out of a desperation for something. And what I would say is, actually, based on that Lancet population level study, is treating vascular risk factor, pursuing a healthy lifestyle, physical activity, and social engagement is going to be better than any supplement or any mind exercise or therapeutic intervention that sort of claims to help patients than anything else. So it starts early. We know that healthier populations have lower risks of dementia, and aggressive treatment of those vascular risk factors, as you saw in middle life, are extremely important. And if you're treating one thing with medications, then it's hypertension, because that is a huge risk factor, not just from a cardiovascular perspective, as you saw, but also for dementia. And screen for sleep apnea. That's also another really good one. I anticipate that on the next Lancet one that's going to come out this year, they're going to add sleep fragmentation and obstructive sleep apnea to the midlife risk factors.
We don't have any more questions. Thank you, Danah. I'll
Of
just
course.
wrap up now. Can you see my final screen here of the slide? Okay. Yeah. So I want to thank Dr. Danah for sharing her expertise with us tonight. This was such a well thought out session, and thanks so much for answering all of our attendee questions. We truly appreciate all your effort into helping our division managing cognitive dysfunction. And thank you to all our attendees for taking the time out to come learn and help improve patient care in our community. Before you go, please make sure to complete this session survey so you can receive your CME credits and improve our future sessions. You can scan the QR code on the screen, but Graveen has also pasted the link in this to the survey in the chat box. It asks for your feedback on your knowledge before and after the session. And then the last few questions ask how to better plan for the upcoming education sessions. So as you are filling out the survey, I'll just read out some of the information regarding our upcoming events. Our next and final Neurology CME will be taking place in person in June 2026 on movement disorders. We'll share more details closer to the date. There's also some information on the slide about how to register for the annual Fraser Health Stroke Symposium, which is happening on Saturday, April 11th. It's a half-day symposium that brings together clinicians, researchers, and healthcare leaders to discuss the latest advancements in stroke prevention, treatment, and recovery. And as part of our other project work with the Jim Pattison Pain Clinic, we have our upcoming CME. So registration is open for that chronic pain CME, which is happening on Wednesday, April 22nd. You can scan the QR code in the bottom right to read more details and register for that. The topics are assessment, interventional options, and opioid prescribing. And as a reminder, we'll be sharing the slide deck as well as the session recording and the resources for you to review after the event. And in closing, I want to thank everyone here for joining us, as well as our neurology working group and the division team for putting together this event. And we look forward to seeing you at the final session. Thank you and good night.
Good night, everybody. Thank you for attending. Hope it was helpful.